Hi, hello. How's it going?
I'm okay.
Can you introduce yourself and what it is you do?
Yeah, sure. So my name is Prashanth. I'm a clinical psychologist by training, and I'm also the assistant manager of operations and services at MIASA. And I also help to oversee and supervise the running of our 24/7 crisis helpline. So yeah, that's a bit about me.
So this is a topic that is very near and dear to me. And one thing that I really enjoyed or appreciated about MIASA and your philosophy is on that peer-to-peer, non-hierarchical, non-dominance approach, because I don't know if it's talked enough about in therapy. There is a power dynamic, right?
Yeah, absolutely. And I think inherently in our system of care, at least when we talk about mental health, but probably healthcare in general, to be frank, there is a tendency to perpetuate that imbalance of power, whereby the power tends to rest a lot more typically in the hands of the clinician or the mental health professional, because in our culture, we see them as the quote-unquote experts, which indeed, I guess you have a lot of specialized knowledge about certain things. And there is a tendency to defer to their judgment, either voluntarily or involuntarily, in a lot of situations. So, and that can be helpful in some situations. There's also some situations where it can be a bit unhelpful, which I guess we'll probably talk about more.
And I get that. It's hard to talk about these things that cause harm in a way that's non-accusatory and non-shaming either, because it does make sense. It provides clarity, it provides structure. Having an expert provides some sense of guidance and assurance. Those are all nice and good things too at the same time. So let's just jump right into it. What is stigma towards mental health issues?
Right. So I think it's a very broad question. If I was being very technical about it, I could say that stigma basically at its core refers to a set of negative attitudes and beliefs that we might hold towards people. In this case, it's people struggling with mental health conditions, but stigma could be applied to any number of other things, right? In the context of mental health, I think a useful way to think about it, and which might get us to not just think about it, but feel what it might be like, is to just imagine that you had a sign hung around your neck, and try to imagine that on that sign was written maybe the worst thing that you've ever heard said about yourself. So this could apply to people who have mental health conditions or not, anyone, right? Just the worst thing that you have heard about yourself. And imagine that was written on this sign, and you were walking around with this sign, right? Number one, what would that feel like? And I think it wouldn't take long for most of us to understand that that would be quite shameful. Like, it would cause us to feel very exposed, very vulnerable, and it would be very painful for a lot of people. So that's number one. And then number two, we could ask ourselves, well, would what has been written on that sign be fair? A fair reflection of us as people. And it wouldn't take long for most of us to say that, no, probably not. It wouldn't be fair for the worst thing that has been said about us to reflect our character as a person. But that tends to be what happens when we talk about mental health. People end up wearing these signs that are statements on their character. So in mental health, you will hear things like, you're crazy, kau gila, you are incapacitated in many other ways, you're a burden to society in some ways. People end up wearing that sign, and they end up walking around with it, and they can't take it off. And everyone is looking at them. That's what it feels like. And what happens when that happens? Obviously, it can lead to shunning, to marginalization of people struggling with mental health conditions. In the worst case, it could lead to discrimination, which is normally reflected in the employment opportunities which may be denied to them, and any number of other things. And what happens when that happens? People are going to feel more isolated, more alone. And if you imagine, the more isolated and alone that you feel, is that going to make things better for you? Are you going to improve with your condition? Or maybe. And then the final stage of that might be, if everyone believes this and sees me in this way, then at some point you might actually start to believe that it's true. Start internalizing the messages that you're receiving from other people. And that's where stigma can become self-stigma. You start looking at yourself with these kinds of labels and so on. So this is probably the best way I can explain is how stigma can manifest and what it looks like, and more than that, what impacts it can have on a person.
I mean, I love that it's very interconnected. I think it shows like what I'm hearing from my perspective, at least, is that stigma has two components. One is the accusation, and then the other one is the interpretation. So I can say, you're crazy, but we also say that's crazy in like a positive connotation. Yeah. And for stigma, that would be one or the other or both.
Well, I guess it tends to always be a negative connotation, right?
Yeah.
Other than, the positive version of that. And that's what ends up saddling people with this perception of themselves and, that kind of all the emotional baggage that can come with that.
And then when enough people have that belief, then they start treating the person who is stigmatized in ways that affect their real world opportunities or resources, things like jobs, things like money, and
even the kinds of relationships they can build with other people. Once you're saddled with that label, people may start to distance themselves from you. So you may not get the nourishment from relationships that a lot of other people.
Yeah, so it's more than just hurt feelings.
Absolutely.
And then the person believes it, and then I guess I would say also that it kind of becomes a cycle, because if my real world conditions are bad, then people would see me being crazy and poor, and again think being crazy is a bad thing when I could be crazy and rich.
Rich. I mean, we've never used the word crazy, but it happens too. Yeah. I mean, people struggle with their mental health.
I could be suffering, from mental health and also doing quite well on, I was going to say, all of that and rich. Is that still a good thing? I'd be in a position of power and a lot of capability to do harm, but this is another conversation.
This was related anyway, to seeking help and things like that, for sure, yeah.
So a review of 17 studies across 11 countries suggested that physicians demonstrate negative attitudes. I mean, based on what you've told me, you're nodding your head. I don't think this seems new, towards individuals with serious mental illness, especially perceptions of dangerousness and desire for social distance. So as a professional, as someone in the field, is this something that you've personally observed as well?
Right. So depending on how loosely we use the term personally observed, I've only been practicing for 2.5 years, which is relatively short compared to some of the other people who I think you're probably speaking to about these issues as well. In that time, I guess it's a good thing. I can say that I haven't necessarily seen what we're talking about happen directly in front of me, as in seeing a fellow clinician speak to, a person who's struggling in very overtly stigmatizing ways. Where I've seen it or observed it is more in other conversations that I might have. So as you know, Clarissa, having been involved with us before, we do a lot of work reaching out to various different groups of people. There are people who come and be involved in the initiatives that we do in various capacities, some of whom are medical professionals or people who are involved in the healthcare sector, for example. Through those conversations, sometimes you will hear stigmatizing language being used, overtly or not. A lot of it has to do with just perceptions of people struggling with mental health conditions in terms of what they're able versus not able to do, general soundness of mind, and also things like decision-making capacity, which I guess at a societal level, you take that to its logical extreme conclusion, ends up manifesting in practices like coercion that end up removing the rights of people. Because if you believe that, this person is incapacitated, they can't make a decision for themselves, then it only seems natural to remove some of their decision-making power from them, which is what leads to them, people finding themselves in situations, often unjustly, where they can't make an informed decision for themselves, right? So you see it manifesting in those kinds of situations. We've also at MIASA heard a lot of secondhand accounts from people who've been through the system directly. In terms of, I went and met so-and-so person, heard a lot of things that I heard, a lot of language and things that I shouldn't be hearing, that is just not conducive to like supporting a person. Again, I don't want to make a blanket statement and say that all medical professionals are like this, because absolutely not. That's not the case, right? But at the same time, I've heard this variation of this account enough times to know that it does happen, and it continues to happen. And if I was to think about it a bit deeper, in some ways, stigma being more prevalent among mental health professionals compared to, say, the general public makes sense in the sense that for a lot of lay people, there's still a lot of people who don't know much about mental health. And as we know with mental health, unless it's certain conditions and it's very severe, the outward appearance may not be obvious anyway. So people may look at someone with a mental health condition, or it doesn't seem like there's anything off with them. So you may not look at them any differently unless you know more about the situation. Whereas in the medical profession, we're all more familiar with the terminology. But I don't know, ironically or not, what can end up happening when you know the terminology is you end up pigeonholing people into those boxes, right? Our minds evolved to put things into boxes for good reason. There's, so much input in the world in general. So it became useful at some point for us to say, okay, anything with wings and feathers and it can fly are called birds, right? And you can put all of it into that box. Even though you may know the names of the specific birds, but you can all put that into one category. Same for anything with wheels, moves on the road, so on. They're all vehicles, right? You put that into the category. So in a lot of ways, that is useful. We evolved to have that kind of thinking is very helpful for us in our day-to-day lives. But there's also some situations where we can end up putting things in boxes and defining that box purely by that standout characteristic. And in mental health, it is the diagnosis, right? And, okay, this person has depression, I put them in that category. And so the treatment is like this. Okay. And we can't talk about that tendency among us as mental health professionals without also talking about the institutional pressures that perpetuate that and incentivize that kind of thinking. Because I'm sure you're familiar, Clarissa. For those who may not know, our system is quite strained. The stat that I kind of always like to refer to, which still kind of boggles my mind right now, is I think WHO did an estimate in 2021, trying to estimate the amount of capacity that each country ought to have for mental health professionals. So if you're familiar with the stat, it said that the ideal ratio for psychiatrists should be 1 for every 10,000 people, whereas our current capacity, or at least at that time, our capacity was 1 psychiatrist for every 100,000. So to put it another way, we only have 10% of the ideal capacity for psychiatrists in Malaysia. Additional stat to that was, ideally for psychologists, so people like myself, for therapy and things like that, the ideal ratio should be 1 for every 5,000 people, 1 psychologist for every 5,000 people. At the time they did that study, the actual estimate was that we only have 1 psychologist for every 980,000 people.
Oh, hey. Okay, that's wild. Yeah.
To put it another way, we only have 0.01% of the ideal capacity for psychologists in the country. It may have improved a bit since then, but probably not markedly, because there hasn't been like a huge increase in allocation. And the reason I highlighted the institutional part of things is because when that's happening, what that means in practice is, and I've seen this firsthand because I've been stationed at hospitals myself for short periods of time, is it incentivizes the putting of people into boxes, right? You only have so much time with a patient or a client. And so you have literally 5-10 minutes in some cases, because there's so many people coming in. There's only so many people to attend to them. It incentivizes moving them on quickly. And so what can you do with that time? I just need to look for the symptoms. And once I've identified that, okay, this is the medication, see you in 2 or 3 weeks, next person in. So the systems itself are incentivizing this pigeonholing of people and being unable to see the person, as you said earlier, because in order to really see the person, you need more time. Inherently, you just need more time to be spent with the person. So when the systems are like that, and I don't want to say like it's a mark on the ministry or anything, because this is not unique to Malaysia. This happens in a lot of other places as well. But when that happens, it can incentivize the pigeonholing and the stigmatizing ways of supporting and treating people. And so I don't think it's the fault of clinicians most of the time. It's, we're all acting within a system, and we do the best we can within the system. But this is what's happening.
Yeah, that's a really good point. And I appreciate that as well, because it's not just a moral or personal failing. It's an institutional. And as you rightly pointed out, maybe it's not so much a failing as it is just we have these real world limitations of money and resources and time that magically and mysteriously exist for some reason, despite the fact that we're making record profits in hospitals. Doctors and physicians and psychiatrists and clinical psychologists do need to find a way to best utilize those resources. So I'm going to take this lovely wide angle and perspective and bring it back to you and ask, how do you experience this in your own mind and reality in terms of like biases and limiting beliefs about the people you see or even yourself?
Right. How the stigma manifests from one person. And so it definitely happens, number one, because as I like to think of myself as quite an open-minded person, as you said, I like to think that I'm quite open to the idea that there are always multiple perspectives, multiple realities that can be true at the same time, etc., without being too philosophical about it. But that notwithstanding, there's still many moments where I fall into the same, traps and things that we've been talking about all this while as a mental health professional. And I think one of the things that I kind of grapple with a lot, well, initially anyway, it's become a bit easier over time, is that kind of core notion of defining a person by their symptoms rather than by their person, right? For example, because the way we're trained is to look for the signs. We're trained to assess and diagnose. So naturally, we are on the hunt for signs and symptoms to be able to produce an accurate diagnosis. And what can happen sometimes is when we have the diagnosis, we have these guidelines where we might have an idea of what the best treatments might be for certain kinds of people. So if, for example, I say I meet someone who I can diagnose with anxiety, has anxiety, then, these are the treatments. And that will typically involve something like introducing relaxation techniques, breathing techniques, anything like that. And there's certain exercises that we might do in a session. If you're not careful, you can kind of become quite beholden to that, okay, anxiety, so I introduce this technique. When in fact, what may be deemed relaxing or what someone may find relaxing or helpful to regulate their anxiety may be different from one person to another. And if you look at it strictly in that sense, you may end up closing off doors in terms of finding what other things can really help with this person's anxiety, what is even fueling it in the first place that may need addressing to begin with. So trying to grapple with that and trying to understand that is something I've had to learn over time. Secondly, and more pointedly, I think as a therapist, what I'm constantly learning, unlearning something else, but in the process learning at the same time, is that there's a tendency when you're, again, going back to the power dynamic thing, the idea behind that is that you're the expert, so you know how to fix me, you know how to address my problems. When in fact, in mental health, it's rarely, at least I've found, to be most effective when we look at it that way. And I've come to learn that the way that seems to reflect my experiences, the reality of the experiences I've had with my clients and people I've worked with, is that I'm not really there to fix them as such. What I'm hopefully there to do, what we're all there to do as therapists, is to provide a space for them to really share. And the task of a therapist, it seems to me, is more to do with just trying to be very, very present and very, very engaged with the person as deeply as you can and see them for who they are as deeply as you can. And oftentimes I found if you do that, there's many situations where I've seen clients come back the next time that in some way or another, they've started to make some changes in their lives, maybe even things that were not discussed in the session indirectly, but they've kind of set themselves on a path to making some of the changes that are more in line with their values and the life that they want to live. And they're doing that on their own. I've just hopefully provided a space for them to feel heard. And I've kind of had to undo that idea of like, I'm not there to fix them or to feed them the answers to their solutions. And this is kind of where hopefully my role as a support person or therapist is there. So unlearning that some of these biases are very chronic, and you kind of have to constantly, it's a process of reminding yourself of these things on with each person that you meet, because I learn so much from them also.
Yeah.
The people inherently have so much wisdom within them And it's not so much about putting new wisdom into them so much as it is just trying to bring it out of them through a conversation. And people have a really remarkable capacity for healing and regeneration on their own. And sometimes they just need a bit of support in moving them along in that journey. So that kind of shift in perspective is kind of what I've had to unlearn as well. And I think there's a stigma attached to that idea. If you take it to its extreme of I'm the expert and I'm here to supply the answers, that can be quite unhelpful in a lot of ways. But it's a perspective that a lot of us, consciously or not, we bring it into sessions. Yeah.
It sounds like you unlearned two things amongst others that maybe aren't coming to mind right now, with the caveat that unlearning doesn't mean that you're not going to have those thoughts anymore. It's just that you know a little bit better that, well, those thoughts are not true. They're not true.
Yeah. It's a process of just monitoring yourself on an ongoing basis. Yeah.
And one of which is how to hold space for multiple realities about what is good for a patient. And also, I think even deeper than that is that you're not there so much to tell the patient what is good for them even, or teach them anything, just again, to hold space for them to realize it for themselves.
Oftentimes.
Again, right, just because something was not helpful or effective doesn't necessarily make it inherently bad. Like, I can totally understand in the ways that needing to feel like an expert can be adaptive for me when I'm a very nervous, very insecure, new clinical therapist wanting to do a good work. And it can also impede those very same goals that I have. So it's not...
Getting stuck in your own head, I think, is quite a universal experience. It's just true of a lot of professions, and certainly in the therapy profession is no different in terms of a lot of self-doubt creeping in and things like that, especially when you're starting, because even when you finish, you're very conscious of the fact there's a lot more to learn, a lot more experience to be gleaned, and there can be moments for sure where you feel like, am I going to be of service to the next person that I'm meeting because I don't know a lot of other things? But yeah, I think what I've learned over these 2 years is that that's okay too, like that's fine. And you need to remind yourself of that. And you don't need all that knowledge to be able to hold space per se. If that is the primary goal, then you don't necessarily need all that knowledge to be able to do that first and foremost.
I guess then the question is, well, what do you need the knowledge for?
Right. So I think, if we talk about things like diagnosis, I think some people have, differing views. Like, taken to its extreme, some people will say diagnosis serves no purpose. And I think appropriately enough for me, if we're talking about people who've just started in the field, I think having that knowledge, which comes with the training, specifically of things like diagnosis, can be very helpful as a guide. As a clinician, as a guide, we use manuals like the DSM, or some people use the ICD. And just having that as a reference is very, very helpful, so that you kind of know what signs to look out for, because that will inform the way you can help the person as well. So I find that to be very useful. And even the more you progress, some people will say, oh, do diagnoses really serve a purpose? I certainly believe they do, because whether we want to acknowledge it or not, symptoms do cluster into these broad categories in a lot of situations. Some may be a bit more subjective, but they may end up clustering into broad categories of symptoms that end up reflecting a lot of people's experience. And so that is where having that knowledge is very helpful. And it's also helpful to the client, because I do believe that I've had numerous experiences where talking about a diagnosis can be so helpful for a lot of people, because when they don't know much about mental health and they've had all these disparate experiences and struggles they're experiencing, now when you have a word for it, it kind of brings everything together. Like, okay, this is what has been happening.
I'm not the problem.
I'm not crazy. There's a word for this, and I can receive help for it. So in that way, for some people, it can bring all those experiences together. Now you have a word for it. Now you have a label for it in a positive way, in this sense, that almost allows you to externalize the struggle. And okay, now this is what I'm kind of up against, and hopefully with the right support, I'll be able to address it. So I've had that experience with some people, and that is where I think the knowledge, especially communicated through a proper conversation, done in the best spirit in the most compassionate way can be very, very helpful for the person as well.
Yeah.
It can also cut the other way, but we can probably get into that.
I love that, the dialectical thinking. It's not just either good or bad. From what I'm hearing is that it does serve a purpose of providing a framework and giving them a way to make sense of what they're going through. Sort of like, I can have a problem that's so big, but you gave me a magic suitcase, I can put it all in. But the problem is not the suitcase. It's this thing that otherwise I wouldn't be able to hold in my hands.
Yeah. And it's a suitcase that other people also have. I guess just knowing that, okay, this is not unique to me. Other people have experience too. Kind of normalize the experience as well.
So it can help physicians know where to look. I guess maybe sometimes people can conflate that with knowing what they will see.
Because two people may have anxiety, but the factors which would have precipitated it may be quite different from one person to another. And that will be important for us to figure out and help you gain insight on as well. And maybe in some cases, it's something quite pressing that you need help in addressing there in order for the anxiety to be dealt with properly, etc. So having those conversations and emphasizing that you have this label, but this is also not all of you. There are experiences which fuel this. And more than that, there's probably resources that you inherently have as a person in your unique experience and your unique existence that can be leveraged to address this or cope with this challenge that you're facing, whether it's in the form of the things you like to do, things you're interested in doing, which when we have a mental health condition, we often become disconnected from. Things like that. The people in your lives, there may be resources and relationships that we can call upon to help you in your recovery journey, and maybe a bunch of other things. And we want to talk about those things too. And that will be unique to each person.
Okay. So same diagnoses can have very different causes, very different, maybe like very different ways that they manifest in symptoms in their brain, very different solutions, very different needs. So all they really do is just provide that structure.
And if I may add just one more thing, like the downside of diagnosis can be sometimes that people end up defining as, I have anxiety and depression, therefore I am ill, and therefore I am less than, and therefore there's always going to be a certain set of doors in life that will be closed to me forever, which may in fact not be the case. But people may end up thinking of it, a diagnosis in that way, and become more helpless in that sense. So that's the other side of, and I've met people who've looked at it that way too. Yeah.
So just to get a little bit more meta now, in a study of 648 clinical psychologists, 2/3 of participants reported their own mental health struggles and indicated the shame and worries about their negative consequences for their careers, and that shame being barriers for disclosing and seeking professional help. Is this something that you've either witnessed or experienced personally?
So I think amongst my circle of the clinical psychologists that I know, I haven't necessarily seen an aversion to seeking therapy or support for themselves in that way. That much. That's been my experience. Although I can understand that there may be certain challenges in that regard. What I mean by challenges, there's certain things that are unique to the profession, I think, that can make it a bit challenging to seek help in the first place. And one being, I think this is like, especially if you're a well-known figure or well-known therapist, for example, the chances are that you probably know a lot of people in the field. The field as it is not very big to begin with. It's growing, but it's not very big to begin with. And so ideally in therapy, you always want to find someone who's impartial, like doesn't really know you outside of the therapy relationship, even like indirectly or know of you, right? That's always when it works best. And so it being quite a small circle of people, it can be hard to find someone who fits that bill. That can be one of the challenges associated with people seeking help. Aside from that, I just to the point that you're mentioning in terms of the shame that was highlighted in the study, there can be, we're talking about self-stigma, and I think as mental health professionals, there can be a tendency for some of us to feel like, we ought to be put together, we should have it all together. because otherwise how can we be doing the work that we do? So what does it say about us if I as a mental health professional also have to go and seek help and support? There can be some of that shame that we attach to ourselves, like, we shouldn't have to, because we're supposed to be put together, kind of thing that ends up happening there. So those may be some of the challenges that some people experience. In my own circle, I've not really seen that much, to be frank. I've had some friends who've been quite open about having sought support for themselves, seem to have employers who support them in those actions too. So yeah.
Okay, so the stigma, I guess, within the field, from what I hear, is that it's not so much, oh no, I'm bad because I've got this diagnosis or I've got this problem. It's more like, I can't do my work well if I'm suffering from these problems, and I need or I should be put together. In fact, I'm just going to reference the American Psychological Association, which considers self-care as a, quote, ethical and moral imperative. And those are some very strong words required to provide sound and responsible caring to clients. And yet, Thompson and colleagues found that most physicians expect themselves and their colleagues to work when they are unwell, despite not holding patients to the same standard. And at the same time, Barnett cites a number of alarming studies indicating that up to 60% of psychologists admit to working despite knowing their distress adversely affects the quality of services they deliver to clients. So on a scale of 1 to 10, I guess the question is, how attacked are you feeling right now?
Not really feeling very attacked. It's not really a surprise to hear stats like that. And why is it not a surprise? Is because certainly there's ethical and ethical questions that are raised in terms of, well, we all operate based on a ethical code, right? In Malaysia, it's the one outlined by default is the one outlined by the Malaysian Society of Clinical Psychologists. And one of the principles they have there is beneficence and non-malfeasance, I think it's called. Basic idea is that you have a duty of care, right, to your client. And part of the duty of care to your clients is to make sure that you're caring for yourself, right? So there's definitely an ethical question there of, part of looking after your clients is also making sure that you're looked after. So that's spelled out there in the Code of Ethics. Where it becomes a challenge, and this is an issue of organizational kind of encouragement and things, a culture, I should say, like that, is we all operate within organizations. And all organizations, like people, really have a lot of blind spots in terms of talking a good talk, but really walking the walk can be two very different things. And there's often a lot of factors that I think as organizations encourage them to see what they want to see and not see what they want to see. I saw a video not long ago, which may seem very unrelated, but actually I think it's related to what we're talking about, which is this guy who has a pet dog and he's trying to get the dog's attention and he's calling the dog's name multiple times, not looking at him at all. Then he dangles a treat in front of him. Then he's like, oh, then he turns and looks at his head. And at an organizational level, sometimes the dynamic can happen. You don't see what you don't want to see, but you see what you want to see. And inherently, certain priorities end up becoming king and go to the top, often at the expense of the well-being of employees. So what does that look like in government? Government, especially in healthcare, it's like the services need to run no matter what. Come rain or shine, the services need to run. We saw this in the pandemic especially. So services need to go. It doesn't matter almost at some level what the well-being of the employees is. So we just need to focus on making sure the care is delivered, even if it comes at the expense of the employees. So that can happen in government. What does that look like in private? It could be, there's a lot of profit-making incentives which encourage, the bottom line needs to be this or whatever it is, the productivity needs to be at this level, well-being of employees be damned, things like that. And I mean, in that sense, at least in both government and private, mental health is not immune from that. In private, a lot of outfits are profit-making entities. And I've heard enough accounts from elsewhere to know that, some of the cultures that encourage this lack of seeking help, the shame for seeking help do also happen within the mental health profession. How widespread, I can't really say, but I've heard that we're not immune. Like any other field, we're not immune. So actually, far from being attacked, this actually makes a lot of sense. And when I hear stats like this, it's in line with what I'm hearing.
Yeah.
I think. Yeah.
Yeah.
So, yeah.
I mean, I do say that partially in jest.
Yeah, of course. Yeah.
And I really appreciate your mentioning of the organizational and the societal structures. And so when I first heard about this, about it being an ethical and moral imperative, according to the APA, self-care has always, not been a term that really sat well with me, because we don't care for ourselves in a vacuum. We don't exist in a vacuum. We cannot possibly provide all the needs on our own. And so it's almost like we're putting the responsibility solely on the individual, this hyper individualistic notion, rather than organizational. Why doesn't APA make it an ethical and moral imperative, which again are very strong words, for organizations to take care of their therapists so that they can do their work?
And to put it like look on the bright side a bit more, there are some examples. Obviously, there's no country in the world that the ethical body mandates therapy for therapists, but there are some individual organizations or employees that, as part of their practice, mandate that their therapists have their own therapy and things like that. So that's like, and to me, there's almost no downside to doing that. Even if the therapist is doing relatively well, it never hurts to have a check-in with someone else. So there's also those examples, which I don't want to ignore either.
Yeah.
Could be a model for how we try and do things moving forward. Yeah.
It's like just broadening the frame a little bit so that people don't feel ashamed or bad or attacked. But based on everything we've discussed, what can clients and mental health care providers keep in mind moving forward?
So for clients, I would just, and this goes out to anyone out there really who is struggling, I just want you to know that you really are not alone. There is help available. As much as you may feel alone right now, there are people who are ready, willing, and able to support you in any number of ways. Mental health practitioners included, because we've spent some time talking about the less savory aspects of the profession, but there are so many people who work really hard, try their best, and stand ready to provide the support and care that you need. So please reach out. In spite of everything that we may have talked about, it's so important to reach out, and I hope some resources will be provided to people like to you guys out there who may be struggling. And then for the community at large, but also I guess my fellow practitioners themselves, I would just urge whatever I've said doesn't come from a place of wanting to besmirch or single out bad actors or name and shame people. Far from it. It comes purely from a place of wanting us to kind of just take stop and reflect on where we are as a profession, what could we be doing better, and also just acknowledge that as all the training and knowledge that we've acquired, I'm not going to be sit here and dismiss that. It's very important, and I think it's very, very helpful in a lot of ways, but it will be useful for us to keep in mind that the learning hasn't stopped or will not stop here, and there's so much more learning to be done, and obviously doing things like continuous reading, journals, things like that, all good and should be encouraged, but also maybe seek out perspectives outside the profession as well. What I mean by that is like patient groups, peer groups. There's so many accounts, especially with the internet now, to learning new things, taking stock of the way we've done things, and really thinking further about how can we be doing things better. And as we said, that doesn't also need to happen at an individual level, organizationally, whether it's private bodies or even at a government level. We need to continue to be having these conversations to come up with better ways of allocating resources in the best way possible, increasing resources if needed, so that we can address this in as holistically a manner as possible, because that's what will be required for us to be able to deal with some of these ongoing challenges in any meaningful way, really. So I hope, we can all continue to work together in that way. Yeah.
I love that. Keep your mind open, keep your mind flexible, and under that same logic, if you cannot keep your mind open and you cannot keep your mind flexible, then know that you also cannot blame yourself for being wet in a swimming pool. We all receive the same indoctrination we're going to be flexible about our inflexibility.
Yeah, we try to be in the best way that we can. Yeah.
All right. Thank you very much. It was a pleasure.
Thanks for having me.
Cool. Do we shake hands? Thank you for listening to Milk Tea Mental Health, a podcast where we focus on the systems and structures and how they affect the individual brain. Please let us know what you think, if you disagreed or agreed with some of the points here, and what this episode means for you. If this is the sort of thing you're into, you can connect with us on Instagram, TikTok, and YouTube. Look for Milk Tea Mental Health, and I look forward to seeing you there.